I just want to say, like, I am so blessed, Dr. Mason, to have your care. Dr. Mason is the head of medical oncology at Scripps. I've heard people sing your praises, up and down the system to say, oh my God, you're so lucky to be getting Dr. Mason's care. And so I wanted you to see what this is the third part of the arm, the third part of my team, which is the best of neurosurgery, the best of radiation therapy, and this is the best of medical oncology within the Scripps healthcare system that is rated the #1 hospital in San Diego for getting care. So just imagine the camera's not here.
So I last saw you a couple of weeks ago.
Mm-hmm.
How have you been?
Fantastic.
Any new health problems or anything I should know about?
No, I've just, initially I thought I had a mild headache, but it was mild and it never came back. So I feel really blessed to.
So you're doing okay there. You're on a tapering dose of dexamethasone? Are you
Yeah, I'm on 1 milligram twice a day right now.
Okay. And you're still on Keppra?
Yes.
Okay.
That's 500 twice a day.
And I know we had our tumor board, our multidisciplinary conference today. I don't know if Dr. Trivanini or Barnett reached out to you yet.
Yeah.
So we reviewed everything. They anticipate starting radiation on Tuesday.
Yes, I know.
Okay.
And
So we've put in the order set for the combined chemotherapy.
yeah.
So our job now is to make sure you get that by Tuesday. If it misses by a day or so, it doesn't matter, but I want it to be about Tuesday. So your pathology was reviewed at UCSF. We
Yeah.
used Dr. Perry up there, who's an expert neuro-oncology pathologist. And so we have Dr. Perry review all of our cases, or many of them anyway, and we agreed this is a glioblastoma.
Yeah.
So we need to use the combined modality approach, where we give chemotherapy with the radiation, and then we do the maintenance chemotherapy afterwards, like we talked about.
Yeah.
The other thing that we could employ, I alluded to it last time, and that was these tumor treating fields.
Yeah, I've been looking.
You looking at that a little bit?
Yeah, and so I'm actually enthusiastic about going forward with.
So Dr. Barnett's going to meet with you, I think, next week.
Yeah.
I think the 10th or something like that. Don't count
The
the
7th,
date.
Monday.
It's on Monday, a meeting.
A Zoom meeting, yeah.
A Zoom meeting, with Dr. Barnett. I think it's one more thing you can do, which might help to slow down the
Yeah, and what I love about it is that, I'm getting quite philosophical about this, and I'm feeling a lot of loving energy. So the way I've rationalized it is, it's just another form of energy blessing my brain.
There you go.
It's
Exactly. And so I think, it's a reasonable thing to do. You're the dawn of evidence-based medicine, and I'll be honest, when this first developed, I was a little bit skeptical, but there is science there. There's pretty good science.
Yeah.
And it's one more thing we can do. The downside is negible, other than just the physicality of it.
Yeah.
The temozolomide, let's talk about again for a little bit. So
Can I ask you, just before we go further?
Yeah.
The pathology, because Dr. Malone looked at the pathology, and I understand that first of all I have an early, the one thing that's going for me is just in terms of the size of the lesions and where they are. That's the positive. Was there anything on the histology that gives you kind of a sense of optimism in any way, or is it just this is the most, and I'm okay if you say it's the most aggressive form of grade 4 glioblastoma, but I just wanted to know, is there anything that provides some form of reassurance, and in particular, there's a genetic marker for whether or not how likely the temozolomide is going to work.
MGMT.
The MGMT. So
Right.
I just wanted to kind of get a sense of
Which is what I don't have back on this report yet.
Okay.
I've got everything else but MGMT.
Yeah.
So it doesn't change what we do, it just changes the likelihood of how successful it is.
Yeah.
And I don't have that back. Can you double check that we don't have the MGMT back? Because on this report, it's not back yet. That's okay, it will come back, but I just don't have it yet. We've got the IDH back, of course, it's wild type, but I don't have the MGMT on this yet. That's gonna be back. No, not yet. So we'll need to get that, but it doesn't change what we do.
Yeah.
The only time it makes a real difference in what we do is in the very elderly, where
Yes.
the benefit of the chemotherapy is not clear, and so sometimes what we do then is we say, well, look, if the MGMT is such that the benefit's even less, perhaps we don't do it. But when somebody's otherwise young and healthy, we move forward with,
Right.
with the chemotherapy. So, no, it's an aggressive tumor. We need to be clear. It is an aggressive tumor. It's
Yeah.
IDH wild type. It's a grade 4. But you don't have a lot of tumor. The location was relatively small. locations, it's more than one. And you're in great physical shape, and you've recovered beautifully from the surgery, so you have all those things going for you.
Yeah.
So, I think we get started with this. We do serial follow-ups every couple of months by MRI scan, so we make sure it's working well for you.
Great, great.
Then you have temozolomide, you've been reading about it a little bit.
Well, actually, I haven't, because
Okay.
I think I will read up about
Okay.
it, but I wanted to just start out by I know it's standard therapy.
It's very standard. It's been standard for about a little bit over a decade since Stu published his publication in New England Journal of Medicine,
Yeah.
showing that people did better if they were taking the temozolomide than not, along with the radiation and surgery. It's easy medicine as we go, for the most part. It's oral. The dose is based upon your size, and I already calculated that out and put in the prescriptions. It can be associated with a little bit of nausea, particularly when you first start taking it. It's not a cumulative kind of nausea like with some
Good.
medicines. It's actually front-loaded. So in the first few days you take it, you might get queasy. So I'm going to recommend that you take preventative anti-nausea pills.
Okay.
And then if you find that you're doing great about it, that's fine too. You can back away on that. But initially, I want you to take some anti-nausea pills.
Great.
The other thing that it can do is it can lower blood counts. And so in the first set of treatments, when you're getting the radiation, I want to check your blood counts about every 2 weeks, just so I know where they are.
Okay.
Most of the time, it does not lower the counts enough to matter.
Great.
Once in a while, and it's hard to predict in whom it's going to occur, the counts will go lower than I would prefer, and I need to know about that. So that's why I like to check it every couple months.
Okay.
A couple weeks rather.
Right.
Once we get to the maintenance phase, we'll just check it right before each cycle along the way.
Okay.
Okay?
Okay. So am I going to be on? Is it 5 days on and then a weekend off?
No. So the radiation will be 5 days on, weekend off, but the temozolomide will roll right through the weekend too. So you'll take
Okay.
it on every day of a week until you finish the radiation.
Okay.
So you'll start it with the radiation and you'll end it with the radiation. If you're off by a few pills or miss a day or two, do not worry about it. Don't double dose to catch up or anything like that. Just don't worry about it. But you'll take it on the weekends as well.
Okay.
Okay?
So it's going to be a solid block. Okay.
Basically 42 days.
42 days.
Yeah.
Straight chemo.
How many pills a day?
It's going to depend upon his calculated dose. So it's going to be probably 2 to 3 pills per day to give him the correct dose. And the computer will tell us exactly what it is. It comes in different sizes, and there's going to be a certain dose for him. So we'll have to mix and match the different sizes to come up with the correct dose for him. Usually it's 2 or 3 pills a day. And that's it, and then we just keep an eye on you, make sure you're doing okay. I want you to stay active.
Right.
It's very important to stay active. Having a brain tumor increases the risk of getting blood clots.
Okay.
Because there are chemicals, thromboplast and other things that release the brain tumors, and so there's an increased risk of DVT. So stay active. Healthy diet. I know you're already doing those things. It sounds like you're working with Mimi on some
Yeah. So
some things.
and I'm going to be doing. There's some of the things we're doing in the integrative medicine.
Yeah.
I'm working with Mimi. The integrative holistic medical team is Mimi.
Yep.
It's, I don't know if you know Patrick Hanaway. He was the director
Yes.
of functional medicine at
Yes.
Cleveland Clinic.
Yep.
And I don't know if you know, he had cancer himself. He had I think stage 4 throat cancer.
Okay.
And he worked with actually somebody in traditional Oriental medicine who's been doing integrative oncology care for 23 years. And he used, Mark Hyman recommended Nalini Chilkov. I don't know if that name's familiar with you. So anyway, Patrick, and I know throat cancer is a different ball game. He's cancer free after, after 2 years. And so he sent me a whole package, including, some additive information about diet.
Okay.
And so I know that you were familiar that when we spoke last time about the ketogenic diet,
Yep.
that might provide a differential benefit.
Mm-hmm.
I don't know if I can get into, I've cut out all sugar. I've gone completely organic. I don't want to put any steroids at all, or any hormones in my body. So I'm eating clean, and I don't know if that's enough to get me into ketosis, but I just want to be clean on that. And then, would you be open to having a conversation either with Mimi or my team, because there are recommendations of supplements, but I want to make sure that when we're in radiation therapy, I just want to make sure we're all aligned.
Yes, absolutely. Are you already on some of the supplements?
No, well, I haven't started, and I'm getting mixed messages and saying, that, and I know that radiation therapy is that we need to go off antioxidants.
Right.
But I think what I'm understanding is that there's some subtleties, it's just not a blanket statement, that it,
Lots of subtleties, there's lots of
Yeah.
nuances, I guess, if you're
Yeah.
worried for this. So, what I'd recommend is that we talk to your team there at the Pearl regarding what you're gonna be on and kind of work that out. So there are some issues with radiation, and I probably want Prabhakar to chime in on that. But there are also issues with the temozolomide, perhaps not as many as with some drugs,
yeah.
but there are some issues, and so,
So if I know that you and Mimi are good, Dr. Guarneri, you are really good friends.
oh yes,
Yeah, okay, so
many years.
maybe yes, but you go back a long way. So maybe the point of contact might be most comfortable for you with Mimi.
Sure, absolutely.
And then we can kind of line up those recommendations. And what I would like to do is I want to really optimize, because I've got an aggressive brain cancer.
Yep.
I want to actually do as much optimization wherever I can get an advantage.
Yeah.
So if it's down to you can take these supplements, but you can't take those supplements, I want to really kind of know how I
Yep.
can take full advantage.
I understand, and that's what I want too. I want to make sure you're not taking anything which could undo what we're trying to do with the
Yes.
initial treatment.
Yeah.
And that's really the issue.
Yeah.
It's rarely toxicity.
Right.
That can happen, liver toxicity and other things, but more commonly we're worried about undoing what we're trying to do here by neutralizing whatever. There's certain types of chemotherapeutics we use, for instance, where certain supplements will simply neutralize them.
Yes.
And
yes.
that obviously doesn't benefit you at all. So I'll talk to Mimi. Do you want me to reach out to her? Or how
Yeah,
do I do this?
if you can just, I give, Mimi's got access to Epic over here, so she's following
Okay.
along
Okay.
in
Okay.
my case. And then just to say that I've asked you to work together,
Yep.
so it'll just make things streamlined.
I'll give her a call. It's fine.
Okay.
Absolutely fine. Yep. I think it's a good plan.
So I have some other questions over here. Do you have anything else that you want
No,
to?
I'm just gonna do a little exam, and then we need to get some fresh blood work. It's been a couple weeks, you've been on steroids, so before you start, I'd like to know where your baseline labs are.
Okay.
So if you don't mind, I also wanna get another CBC and a CMP, just to know that you're okay.
And the CMP
Comprehensive chemistry panel.
Okay, obviously.
So most of them looking at your glucose, liver, and
Okay,
kidneys.
okay,
Yeah.
I got you.
Yeah.
So would it be helpful to ask the questions first
Go
before?
ahead,
Okay.
absolutely.
So, and this.
Oh, by the way, can you tell if he's in ketosis from this
So-
blood thing?
Not from a lab's eye drop. I was gonna digress to that. You know, there are, and I'm sure you know this, there are kits you can get where you can measure your ketones
Yeah,
and you can figure out whether or not you're establishing a ketonic state.
right.
So if I were going to do it, and I was going to go onto a ketogenic diet, I think I would do that just to know that I'm where I'm supposed to be.
Yeah,
Because it is a bit of a lifestyle impact.
yeah, yeah.
Yeah.
And if you're going to have that lifestyle impact, which will affect the quality of your life to some extent, I mean, it depends on who you are as to how much it does, but it will affect it in some ways. It'd be nice to know that you're doing what you're trying to do.
Right.
So I'd probably these kits are not terribly expensive, and see if you can,
Yeah.
measure that you're in ketosis. on
Are
a
they
regular
just the
basis.
strips? Like, are they
There are different
urine
ways to do it,
strips
yeah,
or
exactly.
blood?
No,
Because I saw there's some kind of pinprick
yeah, it's
thing on your
usually
finger.
blood.
Yeah.
So blood is
It's
probably
easy,
better.
it's just a pinprick thing, yeah.
Yeah, so that's what I want to know because I'm in charge of all the
Okay.
cooking for him, and he's been really good at sticking to it.
She's amazing.
And
She's
yeah,
amazing.
so I'm
Oh,
really
she's been
curious
so
to
good.
see
No,
if we
I think
are.
it's worthwhile to look and see if it's actually happening.
Yeah.
Exactly,
Yeah.
yeah. Yeah.
So, I think you answered some of these questions. By the way, these are the questions that Sue just put together,
Okay.
just typed in over here. And so, after those 6 weeks, do we then start cycling, on rounds of temozolomide?
Yeah, so we'll do the 6 weeks, and then we'll give you a month off.
Okay.
A solid month off, don't have to worry about a thing. Then we start cycling with the maintenance treatments, and the maintenance treatments are a different dose, they're twice the dose actually, but only 5 days a month.
Okay.
5 consecutive days a month. So you do days 1 through 5, usually I recommend Monday through Friday, but you don't have to do it that way. And then we give you, it recycles every 28 days.
Great.
Yeah, it's actually quite easy.
And that's as long as I have the cancer, just when
Yeah,
it is.
so the original study, it's a great question, the original study was 6 months. It kind of morphed into 6 to 12 months in clinical practice, and most people do 12 months.
Great.
It's very controversial as to whether you should continue it after 12 months.
Okay.
Have I? Yes. Usually in a setting where someone's tumor has clearly responded and is responding, but isn't fully responded, they're not in complete remission. And so it just seems logical to keep going. If we're at 80% and dropping each month, we'll keep going longer.
Right.
But if you're already in remission, and which is what we hope will be the case with you, and we're out 8 months, we'll probably go those final 4, but usually we'll stop at that point and watch.
Okay,
Yeah.
then, and that gives us some runway to look at
Right.
it. So, and I think we were talking about that nausea is the main effect. Are there any other side effects I should anticipate other than the blood count, depression?
Nothing major, no.
So it's, fantastic. Okay, so ultimately, how long, I guess after I take I'm a little bit, actually, it's an adventure, so that first pull is going to be interesting to me, in terms of, what my response is.
Do you get nausea easily? Do you get motion sickness, for instance? You
Well,
go on a boat, do you get sick, or in
No,
car
I
when
think
you're
I would
driving?
say I'm just average. I'm not hypersensitive.
Most likely you'll be perfectly fine.
Well, that's great
Yeah.
news. So there's some troubling news clearly in the pathology report. So I'm looking.
Yeah.
What I'm hearing is I'm actually hearing an abundance of good news. And then you were getting what meds are you going to give me for the nausea?
Probably Zofran. That's
Okay.
the one we use the most. Now, side effects of Zofran are headache, and there's no free lunch, right? Headache and constipation.
Okay.
It's usually not a big deal, and obviously the benefits outweigh the risks, so we want
Right.
to use it that way. But just be aware, if you get a mild headache, it's not your brain tumor, it's the Zofran.
Thank you for letting me know.
Yeah.
That's helpful.
Particularly in my brain tumor patients, I like to mention that because obviously the first thing you think of is it's my tumor,
Yeah.
but it's not. It's the medication, and it
Okay.
causes a little bit of constipation too.
Okay. So okay.
But what it does not cause, and what the old antiemetics caused, sedation, all that, it doesn't do that. So this is not something where you're going to take the anti-nausea pill and need to go to sleep or not drive your car and all of that.
Right.
So it's a better fit.
Okay, and it doesn't have any of the weird stuff like I mean, I'm trying to remember if it tardive dyskinesia, like
Right.
yeah.
So that's the old metoclopramide and those kind of things. No, it doesn't do any of that.
Okay, excellent. We'll figure that out. So Sue asked what to do if Danny if he doesn't feel like eating. Okay, so I think
Have to keep
I think
his weight up.
I think you'll be fine. It's
Yeah.
really uncommon
yeah.
for our patients on temozolomide going through this to lose weight.
Okay.
Oh.
It's really not common.
Oh,
I think
fantastic.
keep in mind that dexamethasone is driving your appetite.
Great.
And does he stay on that?
So should
And-
I go to double the dose with the radiation therapy?
So talk to the radiation doctor. Here's how I usually do it. I let the radiation doctor drive the dexamethasone while you're doing the radiation. After that, I take over again.
Great.
And I'll taper you down. I will taper you off.
Okay.
But while you're on the radiation, let them drive that bus and adjust the dose for us. Okay?
Fantastic. Okay.
And does he stay on the anti-seizure medication as
For
well?
now, yes. Did you have a seizure at any point?
Yes, I
Yeah.
did. It
Then
was,
yes.
it was a miracle because I
That's
came
right.
in here with word block and
That's right.
it discharged my word block.
And that's right, you told me that story, and then all of a sudden it's gone.
Yeah.
Yeah.
But yes, you should stay on the anti-seizure medication then.
Okay.
Yep.
All right. And I'm not driving.
Yeah, thank you.
Yeah. So, okay.
I thought it as I said. Yes.
Yeah.
Yeah.
And then Sue asked a great question. What if I throw up after taking a pill? And it sounds like it's unlikely, but do I take a replacement pill if I throw it up?
Generally, first of all, it's unlikely you're going to throw it up. If you actually see the whole pill there, it's okay to take a replacement pill.
Okay.
But if there's any question at all, or you're just not feeling well, skip the dose. It's
Okay.
perfectly okay. Skipping a dose or two will not harm you in any way.
Yeah. Okay. And then who to ask if problems arise? I'm assuming that I have access in Epic to kind of reach you if
Yes.
ever I need you.
You reach us, we're a team, and
Hey, Jackie.
Hello.
Take a scan over here to a picture of Jackie. Because Jackie, I just
Hi,
want to say,
Jackie.
Jackie
Hello.
has been the most extraordinary nurse over here. The way she kind of she has loving care, and I want to just thank you for your loving touch, Jackie. I
so
just want to honor
we, so
you.
we work very tightly together as a team, so you'll reach us,
Yeah,
and Jackie can always reach me.
okay,
And, but yes.
okay.
Okay, good.
Thank you so much. And then, and do we go through, is there a number that we go through? Do I call a number, or is it going through the, is it quick, is it
Probably
easiest
just
to
send
get?
a message through
Is that the best way to get a
Sending a
hold of you?
message through portal is a great way to do it, because it's real time.
Okay,
Yeah.
all right, so we'll do that. And then, we've spoken about the Optune, and just, so when do we start the Optune? Would that be after the radiation?
Yeah, do
So-
we have to apply for
Yeah,
approval?
so when you meet with Posey, Dr. Barnett, she'll go over that with you. It's approved to start after the radiation and combined therapy is done, so you'd be starting it in several weeks.
Okay.
There's a clinical trial ongoing, but not here, she's doing it up front, but she'll go over all that with you, but typically speaking, we're gonna do it in a few weeks,
Okay,
when you're done for radiation.
okay. And I imagine, do we need to get approval for that?
Yes, so it's FDA approved now, or is it approved
Yeah, I
device
think-
for that purpose?
Yeah,
So it'll get covered okay for your indication.
Okay, great.
good.
So I think our insurance company is probably having a heartache right now and probably needs some actually medical care themselves.
So what is costing them?
So let me actually have compassion for our insurance
For your
company.
For Blue Shield.
Yeah,
For Blue Shield.
for Blue Shield. Let us take a moment to pray for Blue Shield. Yeah, okay. And then Avastin. You know, I know that Avastin, interestingly enough, I work with Genentech.
Okay.
And I know it's approved for that. Would that be something that we can consider? And
So happy to consider Avastin. There's the data in using it up front is weak and hasn't been shown to prolong survival, in my opinion. As a secondary agent, we can talk about it. I'm happy to consider it as a primary agent, but the data in using it up front, and there are a couple of significant studies that have not been able to show that people did better using it up front. It does have a number of side effects, as you probably know.
yeah,
So I typically reserve it for second line therapy,
okay,
along with, you know, additional chemotherapeutic agents. But we can talk about the pros and cons of that.
okay. So we wouldn't start with it, but it could become, because I mean I know Avastin that these tumors are blood vessel hungry.
They are, and it helps to reduce swelling around tumors, no question about it. It helps with radiation necrosis if that occurs, where you get this sort of pseudo-tumor effect from the tissue, dead tissue around the tumor. And it may help in the short term with the tumor growth too.
Right.
But disappointingly in brain tumors, it hasn't been shown convincingly to slow down and reverse the tumors enough to make a difference in, if you take 1,000 people, will they live longer? The answer is apparently no, unfortunately. So it's useful, I think, as a second line agent. I think it's useful when you can't get people off of steroids. I think it's useful when there's radiation necrosis, but I'm not convinced it's useful up front.
Okay. Okay.
Especially given the fact that it does have some significant side effects.
Okay.
Increased risk of blood clots, significant problems with wound healing, even trivial wounds.
Yeah.
So I mean, those are things to consider.
Okay.
Yeah.
So then I'll talk to more about with Dr. Barnett, you know, just about the clinical trials in terms of, you know, what's in the, that would be, that's the right person to talk to.
So Dr. Barnett, for which kind of clinical trials?
Well, you know, just, you know, I'm assuming that everything that we're doing,
Right.
and I don't want to actually forego any, this is standard therapy.
This is standard.
This is standard therapy, so I'm imagining that a lot of the clinical trials are in addition to standard therapy, and that's, you know, so I want to be, I want to find out what else there might be in addition to standard therapy that I might be eligible for.
Okay.
Okay, so, and then, Sue, that was outstanding. You've got, have we asked good questions?
You've asked all the right questions.
Okay.
Now, your wound looks like from here, let's do a
Yeah.
quick exam, it looks like it's healed really well. You agree?
Yes,
You've had no
I
problems,
have no
no
problems
drainage, no issues, and neurologically, you're obviously speaking
Yeah.
well.
Oh yeah, I've actually just finished a 3-day workshop on awakening conscious leadership.
Uh-huh.
That's the finest work I have ever done.
Excellent.
It's the finest work I've ever done, and what I feel like right now, I am in the full bloom of my life,
Good.
and I just want to see how long that bloom's going to last.
We're gonna keep you there. I like it.
So Susie, maybe you go down
So,
there.
so-
And he's been talking
I haven't
nonstop
been
for
sleeping
3
because I'm quite
days.
inspired. You know, so I may not be a common cancer patient with this diagnosis. Have you ever seen a cancer patient this happy?
You're right up there.
Yeah.
Let's take a look here.
Yeah.
This looks really good. I agree. This looks great. Good.
Awesome, awesome.
All right, let me just take a quick look at your mouth since you're on steroids. I want to make sure you don't have any thresh.
Yeah.
And it looks perfect in there. Yeah. And are you allergic to any antibiotics, sulfas, or anything like
No,
that?
no.
It was pretty conventional when you're on the chemotherapy and the steroid to have you on a Monday, Wednesday, Friday dose of Bactrim to prevent pneumocystis or other infections.
Okay.
Yeah,
Yeah.
it's pretty standard therapy.
Yeah, awesome. Well, I've taken Bactrim.
Okay,
Oh,
yeah.
no problems
So
with
we'll
that.
add that too. Take some deep breaths. Perfectly clear. Add your flu shot.
Yes, I have.
Good, excellent. And then, of course, the next issue is going to be
Oh, the coronavirus.
SARS-CoV-2, right?
Yeah,
Yeah,
well,
well,
that
that-
was another question I had, because would he be considered like one of those vulnerable populations after?
The answer is yes. When we'll be ready to vaccinate our patient base yet, I don't know. Things are happening pretty fast.
Yeah.
I had some emails just today on all of that.
Well, here's what my
Wow,
biggest
that's
concern is,
pretty
because my
exciting.
kids are going out, you know, I can't really stop
Right.
shut that down.
Right.
If I got COVID, you know,
Right.
I think the real danger is, I'm not sure if I got COVID, if I'm at increased risk. I mean, I think when I get on the chemo, I might be at increased risk for.
Well, so the dexamethasone does too. So although dexamethasone has been shown to be an effective therapy
Yes.
for COVID, for the infection of SARS-CoV-2, that's only in patients who are sort of intermediate to severely ill. For patients who really aren't very sick, it's the opposite. People don't do as well, which kind of makes sense, because when we first thought about, you know, it weakens the immune system. So that's if you're really sick and your lungs are in trouble, dexamethasone is a useful, very useful medication, maybe one of our most, frankly, but not in the setting we're in now. So I think you're in a risk, sort of an intermediate risk group. You're not real high because your age is good, your health is great. The temozolomide is a total unknown. We have no idea how much that'll change risk, but we do know that chemotherapy is a risk, and it is a type of chemo. So I would just say that when the vaccine comes along, we should take a hard look at it.
Yeah, so here's my biggest concern about that. So I hear the risk. I actually think the bigger risk is, if I get COVID, will I get therapy? Will I get my radiation therapy? Or will
Yes, correct.
will that
So
push
will
it
it
back?
get
So we have
discontinued?
mechanisms to do that. So when this rolled out last March, this was one of our concerns too. So what happens if someone's in critical therapy and they get sick with coronavirus? They're not terribly ill. Can we continue their treatment anyway? The answer is yes.
Okay, that's a
So
huge
we've allocated portions of the clinic, portions of radiation oncology. So in the scenario where it's really important to treat somebody and not interrupt their care, and they're otherwise well enough to do it, we can still do it.
Wow.
And that would include him, right?
Yes.
Okay,
Yes.
so you have no idea how much relief, because my son,
16-year-old.
is agonizing about this.
Yeah.
He's agonizing, he's trying to have a social life, and
Right.
literally, he came home the other day with actually gloves, and he had 3 masks on. He literally, it was,
Yeah.
I've got
But it's
this
really
video.
hard on him
Yeah,
emotionally
no, I
to be
understand.
isolated.
So, and obviously if you got COVID, we would look at that, we'd say, okay, should we interrupt treatment? Does it make any sense to interrupt treatment for 2 weeks? Because that's really probably all we'd be talking about. Or should we march on through? We'd take a look at the pros and cons of that.
Okay, great, okay, well that's actually.
Danny, the other thing I want you to mention is this asthma.
Yeah,
Back.
I've got this kind of cough that
He
just.
has asthma, and that's what he gets with
I mean,
asthma.
Is this
And
a
I-
new thing for you?
Well, I've had a cough that's been going on. It's just this irritating cough. I mean, I don't know if it's coming from my brain, triggering something. I don't feel wheezy. And I'm kind
Let's
of.
take a good listen. Let's
Yeah,
pull up your shirt.
yeah, and I'm.
Yeah.
Now you're welcome to my belly. No,
There you go.
don't switch off, Bill.
Okay.
Take some deep breaths. Yeah. Very clear so far. Keep going. And one more time, please. And one more time. Sounds okay, but there's no wheezing or anything like
Yeah.
that. But I am inclined to get a chest X-ray just because.
I had a CAT scan, right? I mean, is that helpful? I had that CAT scan just a week ago, and I had that cough. Then.
That was on the 12th
I'll
that
take
you
another
had.
look at that.
Yeah, so
That should be good enough.
Yeah. So so I guess one of the things I'm curious about
Right.
is, like, I'm on dexamethasone.
Yeah.
And now I'm actually taking a little bit of Advil.
Yeah.
And it's still
Still there.
still there. Like
Yeah.
like.
So what's happening with him is he's up a lot during the night, and he coughs a lot during the night, but like today during your
that's
workshop you didn't cough at
Didn't
all,
cough at all.
and he was talking. So now he's
So
a
it's
bit
intermittent
like
cough.
irritated. So I don't know if it's more of a, I don't know, something that just happens at night, or
Could be
Yeah.
postural drainage, it could be sinus.
That could be. I mean,
Yeah.
so when there's chronic cough, the differential of chronic cough is, post-nasal drip. You know what else I've actually had? Interesting. I've gone off the Protonics.
Okay.
But actually, I think I know I actually may be having some reflux.
Say you're off Protonix and you're on steroids. Be a little bit cautious of that.
I know, but I went off Protonix because I'm on a low dose of dexamethasone, and there are actually some just nutritional effects of the Protonix.
No, I understand. Protonix is okay, but there's some issues with it. How much dexamethasone are you on now? You're on 1?
I'm just 1 milligram twice a day.
So 2 milligrams a day.
I mean, I don't feel I'm at gastritis risk.
Be cautious of it though, okay? Because you can develop gastritis faster than you realize.
Okay, so it might be interesting because I'm having these reflux symptoms. I do have some acid symptoms.
And that can certainly cause a nocturnal cough.
That could be maybe that's it.
Honestly, that may be it.
Okay.
Try out, do
I
all the
hope
stuff
that's
that-
all it is.
He has 2 internists figuring this out.
So do all the stuff they taught us at UCSF and
Right.
elevate the head
Did you
of
go
the
to
bed.
UCSF as well?
Yep.
Oh my God.
So elevate the head of the bed, do all those kind of things.
Yeah.
and
Well,
see if
I
it
don't
makes a
think I
difference.
can elevate without my
Or-
wife.
or
I
at
have to
least
just elevate my
Your space.
my
there.
space.
Yeah. Try that.
Uh,
See if it makes a difference because it may
yeah.
be chronic. It may be that you're refluxing.
Yeah.
Yeah.
Hey, I just want to thank you for your outstanding care.
Oh, you're welcome.
And so
My pleasure.
what you have just watched over here, if I may, can I just sing your praises in your presence?
Please.
So, oftentimes when I say look at the best available care, I just want you to notice that not only are you watching a medical team, with Jackie in loving support, with Dr. Mason, he is probably one of the top medical oncologists in the country. And what you're watching is his intake that is just extraordinary. But I want to tell you that what touches me more than anything else is your humanity, your compassion. And I feel, love is the best healer of all, and I feel healed in your presence. So I know we're fighting a difficult disease, but I want to tell you, every time I come into the clinic over here, you've given me a template for healing. So guess what other medicine I'm actually kind of getting right now? I'm getting oxytocin.
Yes.
That,
Okay.
and
Very good.
and I trust
Well-
that's contributing to my healing as well.
Well, that's why we're doing this. So
Yeah.
so I'm glad.
Yeah.
These were successful. Good.
All right. Thank you.
So,
Wrap it up?
Yep.
All right.
and we are both from UCSF.
Yeah.
Yeah.